today, and then tomorrow you take it and it's twice as potent. That would not go well. All right. So we already got introduced. Let's get rolling. So first, disclosures. I am the chairwoman of the Pennsylvania Board of Pharmacy, and I am on the Medical Marijuana Advisory Board, but I'm speaking on my own behalf and not on the behalf of any government entities. We have no financial relationships related to cannabis, though my husband sometimes asks me, why not? No. Taking their money is no good. And cannabis has their own disclosures, which we'll talk about, which is that it's not FDA approved for any medical condition. And we want to make that clear as we talk. So I first like to start with gardening, right? It's that time of year. Who has tomatoes? Right? Okay. There's so many different types of tomatoes. There are big, beautiful San Marzano tomatoes to make sauce with. There are little cherry tomatoes, all different colors, all different varieties, but they're all tomatoes. If you eat a tomato that's ripe, it's amazing. If you eat an unripe tomato, it doesn't taste as good, and it doesn't have the same nutritional content. Cannabis is the same. It's a plant with a lot of variety, right? So there's many different components in cannabis, and different ways it's grown will have different amounts of the different chemicals. So you need to know what's in it, right? So THC, which we'll talk about, gets all the attention. It's that molecule that is psychoactive. It brings the high. CBD, next most famous one, and that's really thought of as an anti-inflammatory molecule. But there's a lot of other things in them. And if you actually ate the plant right from the ground, you wouldn't get high from it because it hasn't been activated, right? It has to undergo heat or some other changes. So it's important to know there's a lot of things in it and there's a lot of variety. And that's why you need guidance when selecting products. And we'll talk a little bit about other things. CBN is also worth mentioning. Cannabinol is a chemical. It's the only other psychoactive molecule in the plant. It's only about 1/10 of the activity of THC, but it's associated with sleep and sedation. Not sure what I did to not be able to advance that slide. Somebody might be able to help figure out, maybe I got excited and over squeezed. Sometimes that happens. Anyway, so the plant is important to understand that there's different characteristics. Okay. But then also, let's think about what it is in our bodies. So those are cannabinoids that are in the plants. Fancy word, phytocannabinoids. But in our body, we have something called endocannabinoids. We have things in our brain that are making these chemicals and in our body. And they work in certain ways. So firstly, here's a heat map of cannabis receptors in our brain. So CB1, CB2. And the warm areas are where it's more concentrated. You'll also see more CB2 receptors, but in the body, and that's also another heat map. So a whole lot of activity in the liver, the spinal column. So we think about cannabis on nerves, right, and neurons. Think about this. We learned that people take drugs like serotonin reuptake inhibitors, right? Serotonin's a happy chemical. It's a common antidepressant, right? Dopamine. A lot of chemicals in our brain work one way, right? They're traveling and they're telling one nerve, telling another nerve what to do. And that's how we kind of think about things work. But your endocannabinoids actually turn off the other receptors. They turn off the release of other neurotransmitters. So it's a balance that happens in the body. So endocannabinoids decrease other chemical signaling, both in the brain and then also in the immune system. So it's really important to kind of think about that. When we have areas of inflammation in our body, right? You fall, you twist your ankle. Believe it or not, white blood cells rush to the area and then send up signals and say, hey, everybody, there's an inflammation party in somebody's ankle. Everybody come and party. Endocannabinoids can actually reduce the movement of white blood cells to areas of inflammation, which is interesting and it's important, and that's why we think about it for inflammation. So we're going to talk about THC first, and it comes in different forms. Well, let's first think about it, right? Euphoria, pain relief, it can relax the muscles. Those are usually some of the things people are looking for. Dry mouth can actually be very helpful in end of life and hospice patients. But when you're smoking it, chronic bronchitis. For patients, dizziness, weakness, increased incidence of falls, which is extremely real and absolutely a concern for patients. That's why when we talk about when you take them, if somebody was going to try THC for the first time, I always tell them, try it in the evening, maybe 5 or 6 p.m., where after you take it, you can just sit on your couch, right? You don't have to get up and move around where you'd be at increased risk of falls. And if you don't like the way you feel, you can go to sleep. But you have to think about it. THC works like a light switch. It turns on the light, it's activating. But Doses are everything. At low doses, we think about THC and it decreases nausea and vomiting, which is great. Um, can stimulate appetite, and it may decrease anxiety at low doses. But once you get to high doses, it can actually cause a cyclical vomiting syndrome where people will have abdominal pain and have trouble stopping throwing up, right? Too much cannabis, anxiety, paranoia, right? Cannabis-induced psychosis. So really the dose makes the poison. At low doses, the thing it treats, and at high doses, it can cause those same symptoms. And what happens is you get muddled in between. Also, impaired thinking and cognitive function, which I'll talk about. And let's not forget THC in the heart, right? So you have cannabinoid receptors in your heart. Actually, there was a very interesting drug years ago where they tried to block cannabinoid receptors in the heart because it helped with atherosclerosis, like buildup of fat in the vessel, which was great. It was effective, but patients were suicidal because endocannabinoids are a happiness chemical, right? But my point in telling you that is you have receptors in your heart, and THC increases your heart rate and decreases your body's efficiency at using oxygen. So you have to be careful. If you've had a history of a heart attack, THC may not be for you, right? Increased incidence of death if you've had a heart attack and you continue to use it with respiratory products, right? So inhalation. So something to consider and talking to your doctor about. And we also talk about cannabis and cognition. So I know this gets a little bit nerdy, but when you look at this chart, right, when you see the zero, everything to the right of the zero would be cannabis makes it better. Everything to the left of the zero, cannabis makes it worse, right? And the further left it is, the worse cannabis does for your brain. So you're learning, abstract thinking, speed of processing. Cannabis adversely affects this. So you have to think about that, especially when you're using these products and making decisions and going out in the world. Now let's talk about cannabidiol, right? Cannabidiol has different effects, right? Anti-inflammatory is what we most think of for this. It's used as an FDA-approved product to decrease seizures, but it can have some issues with headache and diarrhea. One thing that's worth noting is it also decreases appetite. And that may sound wonderful to some people, but if you're a cancer patient, CBD is usually not the best choice for you. There's a lot of other stuff in cannabis. This is for nerds who want to look at my slides later. I'm going to keep rolling along for time's sake. When you go into a dispensary or people talk about it, they talk about cannabis indica and sativa. Some cannabis is very uplifting. Some cannabis is more sedating. Indica is considered in the couch, right? A body high. But I will tell you, this scatter plot looks like nothing that is a pattern, right? You look at it, it's like this is nothing. This is genetic plotting of cannabis by strain names. And what it basically means is the strain names are made up, right? There's no intellectual property associated with them. So you really can't go by a name on a bottle. You really have to see what's in it, the amount of THC and CBD. So let's just go over a little bit what cannabis may help with. So first, knowledge question. You take a cannabis edible, right? Also known as a troche. In Pennsylvania, edibles are not legal, but troches are chewables that you can take. And you don't feel anything after 30 minutes. What do? Somebody's laughing. And he's laughing because he knows, right? So I've definitely had patients say to me, well, I took a cannabis gummy and I waited 30 minutes and it didn't work. And he's like, I used to smoke weed in the 1970s. And I'm like, sir, I don't think that has anything to do with today. So let's wait for it because we're going to get to this. So we'll have a fun graph. So I think the first thing I always like to caution people is when I think about cannabis clinically, I think about it for management of symptoms. I do not think about it for treating disease, right? If you have osteoarthritis, cannabis can help with pain. Could CBD help with the inflammation? Maybe, but it's not reversing the course of your disease, right? I think that's important. If you're a cancer patient and you have nausea and vomiting and you're losing weight, right? Taking cannabis may help you not feel as nauseous and may help you be able to sit at the table with your family and enjoy a meal without feeling nauseous, but it's not going to make you gain weight. So it's just important to level set perspectives. Treating symptoms, not yet for disease. If this was an all doctors conference, I would bust out some crazy slides, but we're not ready for that and it's not approved. So that's science phase 2. But I just like to remind everybody, again, not FDA approved. Here's possible medical benefits. Chronic pain for THC. That's definitely, it's really, I would say, a very thoughtful place to be. I was saying earlier, I teach a 4-hour class that's the Department of Health approved for doctors and pharmacists. So if you're in the Pennsylvania program and you have to go to a specific doctor to get certified, I teach one of those classes. I've taught about 2,500 doctors and pharmacists in our state just because I was so picky about the education that was out there and I didn't like it. So I made my own. But when I do that, I talk about pain and cannabis for at least 30 to 45 minutes to review the literature because it's interesting where it's mixed. So it's definitely an opportunity, but I like to highlight the top. What's the slide called? Possible medical benefits when managed in partnership with healthcare providers. I will say patients are fabulous and wonderful, but it's nice to have guidance of doctors because we want to think about that dosing and get it right, right? We don't want falls. Nobody wants psychosis. Next one, nausea and vomiting. I talked about that a little bit again, able to help with those symptoms and help with that stomach discomfort. And we have to think about products, right? If you're nauseous and vomiting, that may be when you want an inhalation product. Pain, I'll talk about when you would use, pain if it's immediate and it's kind of overwhelming you, inhalation is reasonable. If it's long-term, getting on an oral regimen for chronic pain is really the better way to go. Multiple sclerosis falls similar into pain because it's a mixture of pain and just getting yourself going. And cannabis is effective for sleep. THC and CBN, so cannabinol. And you can actually buy products that have predominantly cannabinol, so you can really target what you want. And that's very thoughtful. But a fun fact, right? So plants are amazing, right? So Mother Nature creates the cannabis plant, and there are 2 enzymes in it that make kind of these 2 pathways in the plant. And then, but there's over 100 cannabinoids. So heat, light, and air, right? Degrade these 2 chemicals into like 100 different substances, which is fascinating, right? Mother Nature is so amazing. But if you leave cannabis out at room temperature and sunlight, it will start to take THC and make it CBN. So your cannabis will make you more sleepy the longer you leave it out. I always tell patients, if you're working with cannabis or you have it, you should be keeping it airtight, out of light, and out of sight. And furthermore, I'd say locked up because it's an issue for children. But again, if you want to be sleepy, let your cannabis degrade and be old. And then CBD is known to be effective for seizures. There's actually an FDA-approved product called Epidiolex that is used for seizures, specifically in certain types of seizures that are profound in young children. But I will tell you, epilepsy is a very difficult disease to treat. And usually some patients may be on 2 or 3 drugs, and CBD works just like any other third-line drug. So it's there. It can be effective in the right patient, but it's a difficult treatment, and it's not always a slam dunk. And then also CBD can be effective for inflammation. And then I like to highlight there's a lot of areas that are variable. Fibromyalgia is one of them, right? Fibromyalgia is a difficult disease. It first became published when I was graduating pharmacy school, where patients have pain, but if you take a little bit of tissue and look at it under a microscope, you can't see any difference, right? So it's one of those ones that's more of a metabolic pain. Something's happening with the chemicals. Another good example of this is headaches, right? So I talked to you about how we have these chemicals in our brain, right, in our body that are endogenous cannabinoids. Well, in people who have chronic migraines, if you take some of their spinal fluid and then you take some of their spinal fluid of a regular person, there's a lot less endocannabinoids in the person's fluid, brain fluid, who has chronic migraines. So it's kind of interesting. So there's consideration about low-level supplementation. So I think very differently about cannabis. I think about cannabis like estrogen therapy and progesterone therapy and thyroid hormone. Anybody take thyroid hormone? The dose of thyroid hormone is 25 micrograms a day. Very small, very potent. I think about cannabis in very low doses to really try and replace physiologic levels. When you think about what somebody's taking recreationally, a recreational user may take 10 milligrams. When I talk about cannabis dosing for patients, especially elderly patients and cancer patients, I start with 0.25 milligrams. Really, the dose makes the poison. So I like to also be clear, depression, cannabis is not proven treatment for depression. It's not a proven treatment for anxiety. I know that anxiety is listed as a medical condition for our state, but I really like to make it clear to patients that heavy cannabis use can be associated with causing depression, right? High doses of cannabis can cause anxiety. So I always want to tell people to consider that. Now, having said that, though, when you talk to an MS patient who's taking low-dose cannabis, they say that it'll help with their pain, and it also helps their mood and help them get out of bed in the day. So think about that. Symptoms, not treatment. Okay, that's the big secret. And remember, lots of studies have very small bits of data in them. So that's why you need to work with your medical provider. And then just to back up the claim, I like to highlight that a large group of scientists looked at literature extensively and summarized things the same way I did, but reminding you that worsening symptoms of coughing and bronchitis when you use inhalation products, increased incidence of motor vehicle crashes. I recommend against cannabis use in pregnant women. I think that's very important to know. And Julia will talk about some other associations. So with that, I just like to remind people they're plants, right? Plants can have bacteria and fungus. They're harvested indoors. The dried flowers should not be smoked in Pennsylvania, but are available, right? They use fancy extraction. There's oils, there's vapes. So you have to know which to use. And these are my last kind of 2 slides that I'm leaving you with. Let's talk about inhalation products. There's a lot of stuff on this. Let's look at the graph, right? So right here, this is the x-axis. It says time in minutes, and this is the concentration in your blood, right? Imagine you're inhaling something, right? You breathe in, it goes to your lungs, and from your lungs, it goes right into your blood, right? And from your blood goes straight to the heart, right? That's the first place your blood goes after your lungs, and your heart beats. The first blood vessels off your heart go to the most important organ, which is your brain. So when you inhale, you'll get rapid concentrations right to your brain. So the blue line is THC. You get this peak within 10 minutes. So if you're having issues, that's rapid symptom relief. But just remember, cannabis is more potent today than ever. So you should take one inhalation as a patient and wait 10 minutes before you take a second inhalation. Think about it. Give it time to work. Give it time for you to understand how it feels. So again, quick THC peak in minutes. And then this is a metabolite. Let's look at oral. So graph. Now the time is in hours, right? So totally different. Same thing with concentration. So you take a cannabis oral product, you chew it up, you swallow it, it's in your stomach. It's smushing around in your stomach, drops into your intestines, has to be absorbed, go to your liver to get to your blood. Takes a while. Oral cannabis products take on average 90 to 120 minutes to absorb, and peak effect is felt at about 5 hours, and it can last for 10 hours. So that's this THC blue line. But the red line, remember the red line wasn't very exciting on the other graph? Look at that red line. That is a metabolite of THC that's actually more effective at pain management than THC itself. And it lasts longer. So taking cannabis for pain, I recommend oral is where it's at. Oh, I lied. I had one last slide. Remember, why do you want to take cannabis? What's the goals of therapy, right? What are your treatment goals? Are there reasons why you shouldn't take cannabis? I kind of mentioned history of heart attacks, right? Maybe not a great choice. History of psychosis. Cannabis may not be a great choice. There are some places where you may not want to take it. You have to think about your treatment goals, and that'll dictate THC versus CBD and the dose. Not every route is perfect for everybody. You have to find the right one. And there are side effects, and Julia's going to talk all about disease management and issues. And I like to remember, these are what I'm thinking of: pain, spasticity, inflammation, sleeping, nausea, vomiting, appetite, and depression.
Thank you, Christine. So I'm going to talk about the legal landscape, recent updates, because I don't know if you guys have been really watching the news. I know sometimes I try not to, but there's been some significant updates in the recent months. So first, another knowledge question. Can a product sold legally as hemp get you high? Anybody know? I know you know, but that's a question we'll be able to answer by the end of this. So first, reviewing Pennsylvania's medical marijuana program, I do have all 24 classified serious medical conditions, and then the 2 with asterisks are currently only approved for research. That's traumatic brain injury and type 2 diabetes. Get a medical card. So it can be a long and tedious process, just because you have to register online with the Department of Health, then go see a PA-approved doctor. They have to then submit your approval to the state. You pay the state $50, and then you get your card mailed to you, and that card is valid for 1 year from the date of issuance. And then another important factor is that products in the medical program do come from state licensed dispensaries. So like Christine said, there are a lot of regulations regarding pesticides and labeling. So very important to buy from state licensed dispensaries. And then I have a list of the available products. As Christine mentioned, actually, gummies, as people will know them as, are not actually legal in Pennsylvania. They're not a thing. There's pastilles and troches, which are technically meant to be put between the gum and the cheek and allowed to dissolve. And then, again, like Christine said, dry leaf is only for vaporization or nebulization, not smoking via like burning or combustion. And so then we'll get to the federal law because there's been some changes recently. An important note is that recreational cannabis is still illegal federally. The recent updates only apply to not Pennsylvania, but to state medical marijuana programs. That is the recent reclassification, only applies to state medical programs. So it still remains illegal under federal law, even though some states allow medical use. It is still a DEA Schedule 1, or recreational cannabis is still a DEA Schedule 1 substance. It's illegal to bring cannabis products across state lines. But I wanted to include some important things about employer protections. So in Pennsylvania, an employer cannot fire or refuse to hire a person for holding a medical marijuana card. The only thing that the only restrictions that the employer can put on you are if there is a positive urine drug screen and you're responsible for tasks that the Department of Health categorizes as dangerous or hazardous. So you could also be, you could be limited if you are found to be impaired at work, or if you're in a role where you work with hazardous chemicals, high voltage utilities at high heights in confined spaces, including mining, and in a federally regulated position. But again, I just want to note that the DEA rescheduling only applies to medical products, not recreational uses. So those employer protections, at least in Pennsylvania, should it go recreational, would not apply. And then kind of getting to our knowledge question. So with a sort of loophole that was opened up by the 2018 Farm Bill, we get this hemp gray market. And so the 2018 Farm Bill classified hemp and made its legal definition, any cannabis product containing less than 0.3% of Delta-9 THC. Did not mention any other formulations of THC, which Christine so gracefully mentioned, that they could also get you high and they can have psychoactive effects. So products like Delta-8 THC, Delta-10 THC, and THCA are very commonly sold at corner stores, vape shops, gas stations as hemp, but they can still have significant euphoric effects and psychoactive effects. But the main important factor there is that these gray market products are not required to undergo the same testing that medical products do. So Pennsylvania, the growers are required to test for bacteria, fungus, heavy metals, pesticides, and all of that fun stuff. These gray market products do not. So you do not know what you are inhaling, because usually they're vapes, but you don't know what you're ingesting. And something that's been very common recently is these hemp drinks, these cannabis drinks. They may say that there's 10 milligrams per can, but they are not verifying that by the time it gets to you and it is opened, that it is still 10 milligrams and that it's actually Delta-9 THC or Delta-8 THC, whatever that may be. They're not verifying that. I think it's also important to note that these products are very, very likely to trigger a positive urine drug screen. They do and will likely cross-react with the analysis that is testing for Delta-9 THC because they get metabolized very similarly. So if you have a urine drug screen coming up, that's certainly something to consider because these gray market products do not have the same employee protections. So if you test positive, you do not have the employee protections afforded to you by the DOH with these gray market products. And then another recent sort of update is the the Supreme Court case, US versus Hemani. It was a decision that was fairly unprecedented for cannabis possession and gun ownership. So currently there is a US law that bars any what they call unlawful user of a controlled substance from owning a firearm. What they specifically note is, as a unlawful user, is a person that has committed a felony or somebody that is currently under the influence of a substance. And then so the actual case, a Texas resident, Ali Hamani, his house was raided, and during the raid, authorities found both guns and marijuana. And so they wanted to remove his guns from his home, remove his permit, and that led to the Supreme Court case that you may have heard of. And then on June 18th of this year, the court ruled 9-0 that applying the ban to this specific individual violated the Second Amendment, but they found that the statute does not apply to his specific case. So the statute is still valid. It just does not specifically apply to this specific case because they could not confirm whether or not he was using cannabis while actively possessing or using his firearms. So in terms of what's changed, courts may start to go the route of not treating medical marijuana patients as automatically losing their gun rights. That usually wasn't a thing as it is. It just generally tends to add roadblocks to purchasing firearms because when you purchase firearms and obtain license to carry, you do need to certify whether or not you are a medical marijuana patient, or at least certify that you use non-FDA approved drugs, which would be the medical marijuana. But it's also very important to note that that statute is still very much, I guess, alive and well. So you still have to consider that when making your decisions. And, just to know that the law is rapidly evolving. Do not assume anything. And Christine and I are not lawyers, nor do we play ones on TV. So don't take my advice. Literally make sure you talk to a lawyer to get advice on your specific situation. And so then next I'm going to talk about something that I'm very passionate about, which is safety with using cannabis products. I know Christine already touched on some of it, so we'll kind of slam dunk some of that too. But starting out with THC, Christine did a great job of talking about all of the common adverse events. These are super, the ones when we say, okay, THC, that's what I think of. Then Christine also talked about the heart and circulation, that it could raise your heart rate and your blood pressure, especially right after using, but long-term may actually decrease your blood pressure, so lead to variability. So if you're taking a medical cannabis product and medications for blood pressure, you get a lot of variability in your blood pressure, which might honestly be worse if you are standing up or sitting down and leading to those falls. In terms of mind and mood, Christine, again, hit it on the head with THC can trigger anxiety and worsen anxiety at high doses. It can worsen depression. It can decrease memory and worsen cognition. And the effects decrease reaction time and make it dangerous. So big disclaimer, if you have used cannabis, do not drive. I think that, but you have to say it. And then at very high doses, it can cause anxiety or paranoia, some of which we classify as cannabis-induced psychosis. I have actually seen this. I've done a couple rotations at an inpatient psychiatric hospital, and it is very common that patients are positive for medical marijuana, whether it is recreational or medical, and they're coming in with breaks from reality, seeing things that aren't there, hearing things that aren't being said, feeling things that aren't there. So it is very real. And then stomach pain, nausea, and vomiting. That's that cannabis hyperemesis syndrome. I've also worked in the ED. It is certainly something they see quite often. And the unfortunate thing about CHS, which may be your deterrent for using too much cannabis, is there really isn't great treatments for it. When we think about medications for nausea, we usually think about ondansetron or Zofran. Only works in about 30% of patients. The main actual treatment we use for cannabis-induced hyperemesis syndrome, hot shower, and that's it. For some reason, if you go to the ED, there's less than a 50-50 shot that an antiemetic is going to work for you. So I don't know if you want to take, that chance. And then looking again at more of a pharmacologic point of view. So absolute contraindications. We will never use THC in these patients. Patients that are pregnant or lactating. That is something that certainly we do not recommend. and patients with uncontrolled psychosis. That's something that we've talked about before, but CBD only formulations actually can be used. We talked about the significant adverse events, but the one that I didn't mention is cannabis use disorder. That is a disorder that is, in my opinion, very underdiagnosed and very underrecognized, particularly in the substance use disorder space. And there isn't very good options for decreasing use or sort of medication-assisted treatment, like we do with some of our other use disorders. So just another thing to consider. And then, all of these cautions are exactly what Christina said. Make sure you're cautious if you have uncontrolled cardiac conditions. Do not use inhaled formulations if you have asthma, COPD, or any respiratory conditions. Actually, THC can lower seizure threshold. So we do recommend using in caution with patients with a history of seizure. And we also recommend to use with a lot of caution in patients that are elderly, so 65 and older, because the effects can last for a long time and lead to that weakness, drowsiness, and dizziness that we associate with an increased risk of falls. And then, like Christine also said, wait 30 to 90 minutes before taking more, particularly if it's an oral product. One of our colleagues actually told us a story about a patient who was very stable on a specific dose of medical cannabis. And one day it was his birthday, so he decided to go out to dinner. He ate something a little bit different than normal and actually ended up in the hospital because he was so, the side effects were so drastic that he was not expecting it. And it was because he ate a high-fat meal and not, anything else. And so then CBD generally is more well tolerated. Again, advise not to use if a patient is pregnant or breastfeeding. And it is primarily removed from the body through the liver. So make sure you're cautious if you have a history of liver problems. Christine showed that great heat map where you could see that the majority of endocannabinoid receptors are in the liver. And that's also so there's a large amount of endocannabinoid receptors, but that's also due to the fact that your liver is your body's primary method of removing cannabis from your blood. And then again, any CBD products that you buy over the counter can cross-react with to trigger positive urine drug screens, particularly those purchased at non-dispensary locations because they have the allowance of less than 0.3% delta-9 THC. So depending on your proximity from when you use the CBD product to when you take the urine drug screen, you may test positive. Common side effects, exactly what Christine said. And I think at high doses, one thing I do want to really focus on is the fact that there's a lot of drug interactions and the risk of infection, but we'll also talk about that. So Christine talked a little bit about cannabis and cognitive functioning, but looking at long-term data. The data is very mixed. There's 3 studies here. One showed that there was minimal evidence of cognitive defects. Another study showed that it worsened IQ and had decreased verbal memory, working memory, and perceptual reasoning by late 30s. And there's a lot of studies that are not very clear in terms of what's actually causing these effects. But recently, there was a study published in JAMA earlier this year of over 400,000 teenagers aged 13 to 17 in California. They were screened for past year cannabis use. So if they used cannabis in the last year, they were then followed until the age of 25. And then they evaluated how often these children developed certain psychiatric disorders. So these teenagers that reported past year cannabis use, and these are the numbers that adjusted for any family history or personal history of psychiatric disorders. So it's lower than the original because these are adjusted. They had about a 2 times higher risk of developing psychotic disorders, a 1.5 times higher risk of developing bipolar disorders and depressive disorders, and just under 1.5 times higher risk of developing a anxiety disorder. So that tells a pretty interesting story in terms of whether or not adolescents can and should be using cannabis. So I think the whole the whole point of mine and Christine's presentation is to really give you as much information as we can so that you can make informed decisions. And this is just some of the new information that's out there. But then I also talked about cannabis and other medications. So cannabis interacts with other medications. It affects the amount of the medication that's in your body, how quickly it's removed, and can change how well it works. So it's really important to make sure that you tell all of your healthcare providers, even your retail pharmacist, that you are using cannabis. So some of the main drug interactions that can actually be really significant. So we have blood thinners and antiplatelets. So anybody that's ever had a blood clot or a heart attack or a stroke is most likely going to be on one of these medications. And cannabis can slow how those medications are removed from your body, increasing your risk of bleed. And then if you have high blood pressure or an irregular heartbeat or anything like that, cannabis, like Christine said, can actually increase your heart rate and make your blood pressure very labile, so leading to those inconsistencies, which, you know, a steady blood pressure feels better than one that's up and down and up and down. And then also Christine mentioned the immunosuppressant activities. So in medications that we commonly use for patients that have had maybe a kidney transplant or a liver transplant, some sort of transplant, we use medications to decrease their body's reaction to the new organ. And these levels can then exceed the therapeutic concentration, increasing the chance of side effects. I've read many different case studies, one specifically of a patient that was a couple days post-op from a kidney transplant, and she was acting, I think a good word to say would maybe be erratic and very unpredictable. And upon then getting to the bottom of it and talking to the patient, she was using CBD, and only CBD and only a CBD product. But then upon discontinuation of that product, her mental status became normal again, and all of her vitals then became normal. So that was a direct interaction between the CBD and the immunosuppressant medications. Some other medications, pain and anxiety medications. So we have to think about medications like opioids. So oxycodone, morphine, fentanyl, benzodiazepines like lorazepam and clonazepam, and other sleep aids that might include like Benadryl, or any of the over-the-counter sleep aids that you might see at the pharmacy. Using them together can compound the fatigue that these medications cause and decrease your overall responsiveness and alertness. Another medication class that's important to note is seizure medications. So not only can THC lower your seizure threshold, meaning that you're more likely to have a seizure, but they could also interact with the medications that are controlling your seizures. So medications such as valproate or Depakote, there's actually a significant interaction where it can add undue stress to your liver, can worsen drowsiness, and raise the levels in your body to cause more side effects than you need. Antidepressants as well. So SSRIs, SNRIs, tricyclics, MAOIs, all of those medications are metabolized through the liver. So when using with cannabis, those levels may be variable as well. And then an interesting note about breathing. So we do not have any endocannabinoid receptors in the brainstem, which is the part of the brain responsible for our respiratory drive. So cannabis by itself does not slow breathing. However, when combined with medications that do slow your breathing, such as opioids and benzos, they can increase your sleepiness, increase your drowsiness, and make the opioid effects more commandant. So you're less likely to be responsive, and a lower dose may put you into respiratory distress compared to when not using a cannabis product. And then another interesting thing that I get asked about all the time is the interaction between cannabis and chemotherapy. Cannabis is very commonly used in oncology patients because of that great utility for at least allowing you to sit at the kitchen table with your family and not feel incredibly nauseated. But there have been studies that, mixed at least, show that cannabis can potentially affect how the chemotherapy is working and how effective it is. So one of the main pathways for that is that they're all metabolized, or most of them are metabolized through the liver. So maybe a good way to think about your liver is kind of like a 3-lane highway, And when you have hundreds of cars trying to go down that 3-lane highway, it's a lot faster than if you only have 1 lane. And so essentially taking multiple liver removed drugs at the same time removes those lanes and makes the speed go slower. And then for immunotherapy, specifically checkpoint inhibitors like pembrolizumab and nivolumab, some studies have actually linked CBD to a weaker response. So these drugs were less effective when CBD was present. And I just have a sort of summary slide. So this shows the interactions that are present with THC and CBD, and the more pluses that it has, the more significant the interaction could be. So you could see that alcohol is a central nervous system depressant, meaning that it decreases your inhibitions, decreases your alertability. So it has a significant interaction with THC. Another interesting one, HIV drugs. But this is just sort of for show. And then it's important to read labels and use it very responsibly. So you have to make sure that you're checking the label for the amount of THC, CBD, and other cannabinoids are present in the product. More THC means more effect, whether it's the effect you want, that's the question, but it means more effect and more side effects. And all versions of THC can cause psychoactive or psychotoxic effects. So it's important to kind of add those up because you might be thinking, okay, it only has this much delta 9, but if it has a lot of other types of THC, those can be additive. Another important factor is to buy only from licensed Pennsylvania dispensaries. That's getting around those gray market products because they're required, PA dispensaries are required to have a healthcare professional, usually a pharmacist, on staff at all times to be available for any questions or consultations and to review any drug interactions. And like Christine said, begin with a very, very, very low dose. Some studies suggest starting with 1 to 2.5. For other, for older adults or patients that are more sensitive, we would definitely want to start lower. And the answer to one of the questions was wait at least an hour before additional dosing because you do not want to end up in the ER like that person was. And then start slowly and increase over several days, not hours. So if you take a dose and it doesn't work, try it again and try the same dose for a couple days in a row before you increase. And to always talk about those increases or changes with your pharmacist, dispensary pharmacist, and your care team. And so then our overall key takeaways is, and I know Christine very much agrees with this, cannabis, you should treat it like any other medication. It has pros, it has cons, it has side effects, and it has great things that it does. So use that information and the information that we've provided to you wisely. Understand that THC, CBD, and the other cannabinoids do very, very different things. Like I just said, start low, go slow, and make sure you're reading every label to understand what is in the product that you're consuming. And always share the information like your full medication list, your full disease list, like any conditions that you have with your care team, the dispensary pharmacist, to make sure that they're aware of those as well. And only use PA licensed dispensaries. And an important factor is ask questions and make sure that you're asking questions of the correct people. Sometimes when you walk into PA dispensaries, there are dispensary associates that are not medically trained. They're not required to be medically trained. So receiving medical advice from them maybe won't be the best idea. However, like I said, there needs to be a licensed pharmacist that has taken additional courses to be able to work in a dispensary. So always ask for them. And so then tons of references that are there for your reading. So thank you. What questions do you have?
Okay, so I'm starting with questions. I have two. I have one for Julia and one for you. What should we do first? Let's go with the audience. Oh, you're saying Julia? Okay, Julia. So you showed information about a relationship between heavy adolescent use
Yes.
of cannabis, things like schizophrenia, depression, anxiety, and bipolar disorder. So what comes first, the chicken or the egg? So is that causality, right? That the child is smoking so much cannabis that they end up with these mental health conditions? Or could it be something else?
That's a really great question. And definitely the chicken or the egg scenario does work in this scenario. However, one thing, and I don't know if I could go back with these, like I don't know if I could physically like, oh, okay. So one thing that is important to note about these numbers is that these numbers were adjusted for past psychiatric disorders, for history of family disorders and personal history. So the predisposition may have been there, but when adjusted for people that had the same risk of past psychiatric disorders, patients that had used cannabis within the last year, adolescents that used cannabis within the last year had these increased risks. So that's a great point that it maybe not be the chicken or the egg, but it may sort of be like, bringing out something that was already there and that might have been their only trigger. So do you want that to be your only trigger?
So my whole thing is if you have an adolescent who's using cannabis, one, they should be counseled, two, they should be seen. They should be seen by a healthcare provider to understand why they're taking it. And really, it's interesting, there's a study that was through CHOP, and they put children into 3 groups, right? Children who didn't use cannabis, children who used cannabis more than 3 times per week, and children who used cannabis less than 3 times per week. And when they compared them, the children who used cannabis more than 3 times per week had a lot of issues with IQ, and educational trajectory and outcomes. But the kids who use cannabis less than 3 times per week actually scored better on cognitive tests, and educational outcomes than the kids who never used cannabis at all, which was kind of odd, right? And the thought is, I think when I read the literature that kids who can use cannabis in moderation and use infrequently and control their use were probably more mature to begin and more developed, right? So really, the frequency that children use it, they need to understand, right? Children who use cannabis, they're gonna use it, right? How do you talk to your kids about it? Hey, if you smoke cannabis, I can't stop you, but you should only do it on a Friday or Saturday and never during the week. Never at school, never when you're trying to learn something, because you're not gonna be able to learn. So I think that considering how much cannabis is available for our children, you should talk about these things and maybe talk about that. Now it's your question, okay? You have atrial fibrillation, which is one of the most common conditions, right? Heart conditions. That means your heart rate goes too fast sometimes. You have pain and you really want to try cannabis. You're on a drug that controls your rate, which is not ideal because there's drug interaction. But you're going to do it anyway because the doctor doesn't know anything and your grandkid's going to get stuff for you. All right. So you want to take cannabis for pain. You take the inhalation product or you take the oral product. Oral. Excellent. 2 reasons why, right? Which one's more effective for pain? Oral. And if you're inhaling cannabis, it goes from your lungs to your heart first. So inhalation cannabis will have more effects on the rate of your heart. It will be more acute. Think about it that way. And what's the starting dose? 1 milligram or less. Any questions from the audience?
I just want to, there's one question in the chat, and I'm sure it's in there, but the reference for the adolescent study, is that linked in the,
Yes.
the references at the end?
Yes,
Okay.
it is. So I have an on text or an on slide, and so you can, so you could track it. So it's Young et al, and then the full link and the full citation is in the bibliography.
Perfect. Thank you.
Look, abstinence can actually return cognitive function to normal. In that study where I showed all the domains, after not smoking cannabis for 72 hours, your brain returns to normal. But what do adolescents lose, right? You go to school in 8th grade, 9th grade, I tell this to my people. That you go to school and they make you learn math, not because you have to know that math, because you're laying down brain patterns, right? You're teaching your brain to think a certain way. So if you're taking all that cannabis when you're younger and not learning how to use your brain and making all those interconnections, and that does affect you later. That affects your ability to think deeply.
Are there any questions here in the audience before we take another one online?
So you talked about oral and inhalation, but isn't there like CBD products that you rub on, apply on your skin? And is that effective at all? And does it get absorbed and go into your bloodstream or no? Or
Sure. So that medications that are, or at least cannabis products that are applied to the skin, generally are noted to be most effective for localized pain. And one of the benefits with those topical products is that very little is absorbed into the bloodstream. In terms of its efficacy, that's a little bit more of a controversial question. The most recent, like, large review of all of the data does note that topical cannabis products are ineffective, and so are generally not effective for localized pain management.
When you look at the studies for MS, they had patient-reported outcomes and doctor-reported outcomes. And the patients said that they felt better and that they felt that it helped their symptoms, where the doctor said, yeah, it wasn't really different. So I'll leave it at that because placebos are real.
No, that's a great point.
But they could also have effects. You know, you look at some textbooks and they will say that THC will not absorb through your blood across the intact skin. But there are examples of where people have put THC products on their skin and they have felt impaired and they have fallen. And they have gotten lightheaded and they have had their blood pressure drop. So it depends, intact skin. And also, I hate to say it, we all ladies know it, as we get old, our skin is not the same anymore, right? We don't have the same level of fat on our skin gets thinner, different absorption. So I just want to say, I think be thoughtful, especially as we age.
Yeah, and as well, some of the data that I've done, that I found for previous presentations, specifically looking at disease states like ulcerative colitis and Crohn's disease, do not show that there's a significant impact in the way that your body treats the disease or the actual impact that the disease is having on your body, but it improves the way that the patient feels with the disease. So they feel that they're able to do more than they were before. So I think that's an important thing with, like Christine said, you're treating the symptoms and not the disease. And then I had one more thing. Oh, in terms of the, yeah. Yeah.
Some of them, sometimes diarrhea predominates, and there are other issues. And THC products can affect your GI system. It can affect the dry bowel movement. So different people react differently, but it's definitely having activity in that system. And what's interesting is most people don't think about it, but you actually have serotonin receptors in your gastrointestinal tract. We'll be honest with you, I have a slide with the GI tract and all the things that affect different receptors, but I deleted it. Talk about it later. I have hundreds of slides. So is Julia. The 5-hour version starts tomorrow morning.
Yeah. And another interesting thing, and I don't know if I got to tell you this, when I was at Ascend, or a dispensary local to our area, they actually did have suppositories and transdermal patches. So I don't know if you've ever seen a lidocaine patch, but they did have THC patches that are meant to be applied to the area of pain. And as well, they had suppositories. One of the advantages of that may be if you're unable to swallow something, you can go sort of the other way in a way that you can't throw it up. And as well, they did mention that it could be useful for menstrual cramping because it's acting in the localized area if inserted vaginally.
About how cannabis for many years, but it's not gotten the respect and consideration for its efficacy that the author thought it deserved. But it was published in an 1887 medical text. But yeah, menorrhea has actually long been in use of it, and also they used to call it treatment for dipsomania. So, which was alcoholism in the 1800s, that using cannabis could be a path to stopping using alcohol, which is, again, I mentioned nothing is FDA approved, but something to consider as well.
We have two questions in the chat from the online audience. First one, can you please discuss the study showing that medical cannabis significantly reduces opioid use and overdose deaths?
So I teach an educational program to doctors and pharmacists in our state. It specifically asks you to talk about how cannabis can reduce opioid deaths. And I don't feel like I have information to present that is profoundly conclusive. I think some of the stuff is population studies based on states. So I do not have that included here. I do think harm reduction is real. think harm reduction is very real. And especially when I think about opioid use disorder, and I also think about people who take take opioids for pain and then develop issues where the use of opioids is uncontrolled, is related to a broken pain system. Right? A lot of times, high dose opioids can just make it so your receptors are screaming, a lot of other words. And cannabis, it's interesting, THC can have effects on opioid receptors, so there's a lot of crosstalk. It's hard to answer that question without providing 5 to 10 minutes of information and then putting it in context. So I'm gonna stop there. But there's definitely something to talk about, but I think you also have to look and weigh the merits of the studies. There are data to show in certain states as cannabis has been legalized, opioid deaths has gone down, but there are also other factors at play. So on a population level, on a receptor level, lots to discuss. Sorry, that was long-winded as I would like to be.
Thank you. And I know we're just about at time, but we have 2 more online questions. Anybody else here in the live audience have any questions they'd like to ask? All right, let's take a live question. I'm going to throw it.
Thank you. I was wondering about your observation that cannabis use disorder doesn't get a lot of study. If you could just describe, what is that associated with? Is it associated with THC or CBD or both?
It's largely associated with THC. I saw that very commonly. I've done a lot of rotations, inpatient behavioral health, outpatient behavioral health, and pain management. And there's many situations where patients will note that it or will report effects that would kind of go along the lines of cannabis use disorder. Similarly to where if it was an opioid that they were taking, you would be thinking, okay, that's maybe a problem. And these patients, just because of some of their disease states or some of the other substances that they may be using, working at our inpatient substance use disorder clinics, cannabis, I feel like, is often seen as less important than some of the other substances. So some of the other substances like opioids, stimulants, benzos are very often placed at a higher ranking in terms of the acuteness and the necessity to treat. So stopping cannabis use for an average patient, whether they have a concurrent substance use disorder or in a patient that's experiencing hyperalgesia, very often they don't want to, but because of the other disease states, they may not. It may not be something that's really pushed.
So I would say for cannabis use disorder, there's 2 surveys to decide if somebody has it. And one example we give is, does it interrupt your daily life activities? Were you going to go to your child's soccer game, but instead you stayed home and you smoked cannabis? Many people have caffeine use disorder, right? But does it impair their function? Does it impair the things that they should be doing in life? So that's kind of how I look at it with patients. I usually say it lasts 5 to 10 days, irritability, sleep disturbance, and then also gastrointestinal symptoms. However, it is not nearly as concerning medically. It does not require treatment as like alcohol withdrawal can cause seizures and can be profound. Opioid withdrawal has physical effects. So cannabis use disorder, that withdrawal can be slightly uncomfortable, doesn't require medication. I think it's largely accepting, and managing that.
Thank you. We're going to take the 2 more questions that are online. We do have another online question, but we're going to send that to you after the fact, and any more that might roll in, and we'll get an answer and send that out to all of the attendees. Can you mention again if or which was most effective for migraines?
So I would say very low dose THC, right? So it's not so firstly, it's not FDA approved. This is not proven. There's no good studies that look at it, right? So chronic migraines were shown to have an association, right, not causality, with having lower levels of endogenous endocannabinoids, right? So we're talking lower levels in our spinal fluid. We have very low levels. So what somebody could consider doing with migraines is taking very small amounts of THC every day, right? Low dose, 0.5 milligram. Very small. Think about physiologic replacement. It's not like I have a headache, I'm going to smoke weed. That's not what we're talking about for treatment of the acute symptoms, but it's a possibility that low dose replacement could help. There's no data strongly associated with it. I'm not recommending it. And it's not listed as one of the conditions that you can access it in the Pennsylvania state.
Yeah. And I mean, just to sort of go on that, I've done a few presentations on cannabis use and migraines specifically. Interestingly, and I'll just talk a little bit on the positive end at least for, to give you some hope there. Again, very, very small sample sizes, very limited control in terms of, and that's one common flaw in all of the cannabis related research that we're seeing. And it's a lack of standardization of what the dose is, what the product is, whether it's inhaled or an oral formulation or a topical formulation, and as well inconsistencies in the actual formulation. How much CBD, how much THC, how much of that other stuff is in it that we do know has some medical benefits, like could be linalool, which is found in lavender, which we know aromatherapy for sleep does work. So what's actually causing that effect? We can't draw that definitive conclusion. But there was a very interesting study that I did read, and I could send this to whoever asked that question, that cannabis use for acute migraine attacks did improve the most bothersome symptom at 2 hours and 24 hours, and improved the pain-free time at 2 hours and 24 hours. So those patients,
Was that PO or inhalation?
I can't remember off the top of my head. That's why I said I will find that study and I'll send it along.
That's good. I like it.
Thank you. All right, our last online question for now. Slightly off topic, but in the very beginning, it was said dry mouth would be beneficial in end of life care. Why is it beneficial?
Sometimes in patients who are end of life, they end up with excessive salivation. Hospice care, and we order a certain drug that we give patients to dry out their mouth. So it's complicated end of life. It's a thoughtful balance of making sure you're meeting patient symptoms while trying to preserve whatever cognitive function they have for the amount left. So sometimes in that setting, cannabis can be effective for that.
Thank you.
And in fact, actually, a law was just passed in our state, Ryan's law,
Yes.
which made it mandatory for patients who are on hospice to be allowed to access cannabis while in hospitals. And it related to a young man who was dying of cancer in California, and it was related to end of life. And so I think the big thing and the takeaway from everything is talk to your doctor. And I will say some doctors don't know about all medications. Life is complicated, right? Doctors are so specialized nowadays because it's so complicated. Talk to a pharmacist, and also find pharmacists that are interested. Julia is amazing, as she is a cannabis fellow. Like, that's pretty exciting. So find one that's knowledgeable in the subject that you're interested in and use it with guidance, because again, you don't want to end up exacerbating symptoms that you were trying to treat.
Another interesting thing, we also don't want to treat side effects of medications with other medications. That is, I know as pharmacists, you're like, wait, you want to take away meds? We're probably the first one to rip a med off, because we don't want to be treating a side effect of a medication with another medication. Yeah, I knew that was where that was going. So just because when you were talking about the end of life care, that made me think about excessive drooling with antipsychotics and using glycopyrrolate. So it's kind of that question of make sure you talk to your healthcare provider, because there could be a reason if you're trying to use, or you're trying to get the dry mouth out of it, there could be something that's causing it. And so that's why it's really important to talk to your provider and talk to your pharmacist, so that we're not adding on a medication when simply taking less medication would treat what you want and get the effect that you want.
Final statement, talk to teenagers too.
Talk to your kids.
Thank you so much. This was truly a fascinating and informative lecture. We appreciate you both being here. So let's give them a warm round of applause.